journal presentations, publications. Over to you, Dr. Hegde.
Thank you, chairpersons. Thanks ISOT Scientific Committee and Nasik Forum for the opportunity. So immediate post-transplant infection. We all know that we have to immunosuppress the patient, and hence the infection is part and parcel of it, and we may have an early or late infections. I'm going to cover in the introduction timetable of things, bacterial infection, viral infections, and also the fungal in some. So fever and the physical signs of infection like an erythema are all depressed, signaled because of the immunosuppression, and there will be subtle signs. Sometimes the LFT may be mildly elevated and radiographic abnormality may not be there. So the azathioprine MMF, they lower the counts, and the maximum temperature may not be there. Significant infections such as peritonitis may be masked, and they may have a severe signs and the localizing signs. So early recognition of the presentation may be poor, and they may present with an immunosuppressed patient may present atypically or in a more advanced disease. So hence the treatment may be problematic, and we may have more complications. Fever is non-specific. It may be attributable to immunological disease like an acute rejection. So we have to be careful, and the invasive testing will be required. We all know that the net immunosuppression decides the infection, the immunosuppressive dose, duration, and the sequence, and what we are using, either the depleting agents or non-depleting agents, and the underlying immunosuppression. If they're already received immunosuppression in the past, they may be more prone, and the diabetic and the mucocutaneous barriers like infusion drains and catheters, and the devitalized tissues, and the collection, which will be important. And the neutropenia, especially the lymphopenia, which we neglect, all these patients will have more viral infection, which we have learned from the COVID times, that the lymphopenia predisposes to viral infections. So hence, the balance between the microbe and the host is important, and the host defense mechanisms, and it determines, and the inoculum load, virulence, and it all depends on how early you can get an infection. And if the inoculum load is larger, even though the host defense we can overcome, and it may lead to infections. There are multiple things. If the patient has a neutropenia, then you expect more of a gram-negative bacilli, and even a staph, candida, and aspergillus. And if the patient has a splenectomy, or the patient has received rituximab, then you get more of a capsulated organisms like pneumococcal, H. influenzae, and meningococcal. And the host, if there is an early C3 and abnormality, staph, pneumonias, and bacterial, and lately you can get Neisseria species. So we have to keep in mind what immunosuppression are used, or is there any neutropenia. So lymphocyte depleting agents, if host defense is abnormal, you can get numerous microbes. HIV, you can get the H. influenzae, pneumonia, and you do. So if you use anti-thymocyte globulin as a lytic agents, you give activation of the latent viruses and the fever, and you can have cytokine release encapsulated in B lymphocyte depleting agents. Plasmapheresis also, it depletes the agents and can have more encapsulated. Co-stimulator factors we don't know, but we can get early PTLD has been known, so possibly it may increase that. Corticosteroids, the PCP, bacterial infection, wound healing, azathioprine cause neutropenia, and BK, a polyoma, possibly papilloma virus maybe. And so the calcineurin will have either gingival infections, and mTORs will have wound healing problems and wound infections. So multiple drugs. It may be the donor-derived or the recipient-derived nosocomial, or it may be community-acquired, but this will be a late onset infections. More commonly, it's a recipient or a donor-derived, or immediately after the surgery. So we all know that's timetable. Earlier it was Rubin, and then Fishman, and then we also George timetable for India. Also, in an early, it is a nosocomial infection, or if there is any infection from the antimicrobial, this thing is very known. Early we can have an aspiration, and the catheter infections are known. It is more commonly a donor-derived in some, but it is not always, and donor-derived also present much earlier. And CMV, if there is a donor positive, recipient negative, it presents earlier. So a lot of barriers, like in surgical procedures, it may have baked in the barriers, prosthetic or intestinal anastomosis or impaired local immunity, systemic immunosuppression, and the underlying immunosuppression, especially age, malnutrition, diabetes, they all lead to increased immunity. They may get an early onset of infections. So early onset is more oftenly a bacterial or candidal infections or undetected systemic infection which has been treated concomitant during organ procurement, or it's an vascular access or the drainage or the anastomotic fungus maybe, but after the 6 months you get all more later. So if you have ABO compatible and ABO incompatible, ABO compatible will have a lesser infection as compared to ABO incompatible. If you see the early in the 2 months or 3 months, you get a much higher degree of, because of the plasmapheresis and immunosuppression, rituximab, and you are acting on both in B and C cells, and if you have a ATG induction which you are blocking A and B, T cells and B cells, you get much more. So this, what type of infection you get? Basically you can get more often is urinary tract infection. It is much higher in both, but more so in the ABO incompatible group. Then you get a pneumonia and even wound infection. Again, wound infection you will have more of a diabetic and also obesity. So ABO incompatible will have more, and the pyelonephritis they can have if there is any early urinary tract infection or even asymptomatic. And as far as the infection is concerned, with different transplants, the bacterial will have an upper hand, and the cytomegalo, which will vary as compared to the lung, we have much less. Herpes zoster, herpes simplex can have varicella zoster, but again they can have a later, and the candidemia and pneumocystis is around 6 months. So this is the earliest infections what you see with the time. The surgical infections, lower urinary tract infections, and the upper urinary tract. Even COVID can have any time, and so these are the surgical times. It's only around a month, less than that, or early 15 days. Urinary tract infections can have early, and you can have a CMV infection can be there if it is donor positive and recipient negative. So most commonly what we see is urinary tract infection, wound and pneumonia. So this was the Korean registry of transplant patients of 3,738 patients who underwent a transplant between 14 to 17, and recipients were cut off as elderly or more than 60 or less than 60 years. Early post-op infections were seen in almost around 16.9% in the younger versus 22%, so slightly higher. Bacteria contributed around 48%, and the virus was 31%, and the mycobacteria, it was on 1.2%, fungus was 1.9%. So the female gender, the older donor age, and the longer duration of hospitalization and the acute rejection if they have suffered, they were important risk factors for early post-transplant infections. Bacteria were more common. So this is again another Korean registry of earlier in older patients. It's basically if they have a rejection and if they have things, they have more common as compared to without infection. They are more common if you have a rejection, and the mortality, all-cause mortality is slightly higher, around 4% as compared to without infections in less than 60, and around 8.1% in those who have more with infections in the 60 years. So it increases the mortality, but the others are not significantly higher. So if you could have comparison within the bacterial infection between the ABI and compatible and incompatible, it's a significantly higher. Almost 60% of the patients may be having an infection as compared to 30, but again, all are not major. And the urosepsis is one of the most important, and the pneumonias, you can get it. This is a different follow-ups for months, you can see. Pneumonia is common, but again it is much less as compared to lung transplant, which is 72%, is only around 2.9 to 30%, and the occurrence can happen in the early and late. The diagnostic strategies must be in the post-transplantation, the early diagnosis, and the degree of immunosuppression, hospital exposure, and the empirical therapy also matters. The novel techniques, we have to do an early imaging. So the reactivation of the infections, it may be early or it may be a donor transmitted, if it is a lung especially, but not in the kidney. Hospital acquired will be a gram positive bacilli or even the early months. Opportunistic infections, if the mycoplasma pneumoniae may be there. And so these are all the rapid diagnostic. If there is a rapidity, if you do imaging studies, if there is a lobar consolidation in the early phase, it may be an aspiration or a pulmonary hemorrhage, it may be possibility. So bronchopneumonia, then or in the later stages it will be mold, which I won't touch it, and it's a bronchopneumonia, or then it's possibly a mycoplasma chlamydia. It can be there in the early things. Nodularities will have a fungus, CMV, and the PCP. Diffuse, then it will be possibly a viruses or pulmonary edema or an hemorrhage. And it is associated with the adenopathy, possibly tuberculosis or PTLD, and it's a pleural effusion, then possibly an empyema or tuberculosis. So this is all the evaluation you know, and if it is a low-risk group, then the concern is the hospital acquired pneumonia, treat it. Concern about the community acquired, then empirical therapy. If there is any moderate risk and especially the immunosuppression, we'll have to go as we have to have a blood culture, sputal culture, and you have an evaluation for the serology of fungal and the Legionella, and if there is a CMV also, and if the CT scan, then we need to go for a BAL, and definitely the cultures and the different stains will give us, and accordingly we'll have to go ahead. So the early diagnosis is the key for the treatment. So these are all the treatment with the time constraint. I won't go into the detail. The Legionella, we need to treat it with azathioprine and levoflox. Nocardia, we have to use a trimethoprim. Most of the people are getting the prophylaxis, so you can use imipenem, which also has a good anti-nocardial therapy. Mycobacteria, you can have it, but the early is less likely. You can have it at 3 months, and others also. The infections, the urinary tract infection is one of the most important and frustrating sometimes. It varies with different definitions to 10 to 98%, and the clinical is prophylactic antibiotic which used in the first 6 months, the Bactrim. Sometimes it is not acting, but others which may predispose to the later onset of urinary tract infection, and almost around 72% are in the first 6 months. So the pre-op factors, the intra-op factors, and the post-op factors, they play an important role. The pre-op factors may not change significantly, but you can definitely control the diabetes, female sex, the immunosuppression previously you have used, and an advanced age, and if there is any urinary tract abnormalities, these persist even after the transplant. Intra-op factors, the decreased donor A, donor kidney, diseased donor kidney, and the degestant use, duplex ureter, and the retransplantation, contaminated perfusion, they may contribute to early urinary tract infection or a pyelonephritis. Excessive immunosuppression, graft dysfunction treatment predisposed to infections, and the infection of the native urinary tract infection may increase the chances, and the urinary complication, if it is there, they may obstruct and lead to problems. So it is the pre-transplant factors, and along with that, peritransplant, degestant, everything, and the post-transplant factors lead to asymptomatic bacteria, cystitis, and graft pyelonephritis. And when you have graft pyelonephritis on the long term, if it is a problem for a graft survival, whether the degestant is almost required, and if you see the complications, if there is a bladder is good, you may not require. It is the decision of the surgeon to decide whether to do a degestant or not. If you see in some patients when the degestant was not good, then the perigraft collection and the post drain was very high. So degestant is often used when you have complicated bladder or duration of dialysis or longer, and it may increase the chances of urinary tract infection or colonization, but if you remove timely, it may not have any problems. The urinary tract infection in, say, from the first 6 months of 295 patients, which you have seen that 35% developed a urinary tract infection, and UTI was asymptomatic in 63% of patients, and simple and complicated in 12.4% of patients. The removal of the stent, late removal, and older than 40 years, female gender, and the neurological bladder, they were a predominant factor for urinary tract infection, and the recurrence was also significantly higher. So more than 40 years and the female gender, and especially there is some significant risk, and even the therapy with ATG. So urinary tract infection may not have, if it is treated adequately early and reverse, and there is no recurrence, they may not have any effective treatment on the long term, but it significantly increases as a leading cause of hospitalization. So this was our study. We used around 106 patients for nitrofuran prophylaxis in addition to the Ceftran to see the reduction in the things. So most of the factor as a PUC duration was when it was higher, we saw more number of things. So you can remove there are some literature show that 3 days removal, and the degestant, it was kept on a large, more duration, we have it, now we remove it on the 10th day. So all this creatinine was much lower, number of rejections were less, but if you see that the pseudomonas was increasing, colonization was seen when you use nitrofurantoin. So even though we have less infections, but it was not statistically significant. The wound healing is an important problem, and you see it more commonly in aged, diabetic, and pre-transplant, and the body mass index. And if there is any hemoglobin is lower and albumin lower, this is the study of univariate. And if you see the multi-rate analysis also, you see if it is the BMI is higher and diabetes and the nutrition is poor, you see, and the wound dehiscence is an important factor, and it may create a lot of problems. So strengthening and the post-operative monitoring is an early diagnosis to treat. CMV, if it is a donor positive malignant, you have it, and the ATG induction, it increases the risk and even the microfluidic use. We see around 32% in the global, it's only 13% in India, what we see. And the early onset, if you see, it is most of the patients were contributed by, around 51% of the patients were contributed when you have a donor positive and recipient negative. And the evaluation, it shows that they may have a subsequent episodes of CMV infection. So we have to take care of the early infections are more common with donor positive recipient, even though our country it is much less. It can have it in the first 2 weeks also. The quantiferon assay may give a clue that we may have a CMV infection in the early, or so that we can have more aggressive or increased the dose, appropriate dose of CMV prophylaxis. So there is an torpedo viremia which was shown consecutively when you monitor, and if there is a level threshold is higher, this is one of the virus which is there and it replicates with immunosuppression. This may be an indirect way of predicting the CMV viremia in the future. So if there is any more than 3.45 lakhs, they in the early 10 days, they may be a future candidates for CMV infections. You all know all this therapy and the prophylaxis, and possibly we may go with the CMV cytoloxic therapy, the card therapies for the treatment also in the future. And this is the treatment for resistance. And aspergillus, what we see is basically a vascular invasive fungus, and it is very troublesome. You may have it on the 10th day or a 14th day. Immediate exploration has to be done if there is any rupture or if there is any mycotic aneurysm. We have to be treated, and we have to treat appropriately. The balancing immunosuppression is an act, and these patients have to be monitored, and you can do a monitoring, which is fungal infection is already done with Dr. Sonal madam, and I won't go into the detail. This is one of the publications for the IKDRC which have shown 2010 to 2015, and the aspergillus was very common. So, so the treatment has been dealt. So to summarize, early post-transplant infections are occur within first 30 days, and it may be in the first 3 months. More common infections are post-surgical, and the pneumonias, urinary tract infection, and bacteremias. Early identification is and treatment reduces the morbidity and mortality. And if there is any fungal infection early and vascular invasive, saving the patient is the goal rather than saving the graft. Thank you very much.